Hello and welcome. This is Scott Yoder, and today I'm excited to have you with me as we take a deep dive into the process of a patient being discharged from a hospital following their cardiac surgery. So, as you can imagine, a patient having cardiac surgery is not usually a planned event. It's something that typically catches a patient off guard. What happens is they develop some sort of chest pain, go to the hospital, have some diagnostic testing done, and the next thing you know, they're being told they should have surgery to fix the problem. So I call this a cardiac luge. It all happens very fast. Patients maybe don't understand everything that's going on, even though it's explained as best as possible to them. It's a time of concern and fear for not only for them, but for their family and loved ones. So I went ahead and made a storyboard depicting the scenario. What happens is after a patient goes to surgery, they usually spend 24 hours in the ICU and then they get discharged to the floor. And once on the floor, they are followed by the social worker or case manager. And this case manager or social worker sees the patient every day and checks on the progress. And their role really is to, once the patient is ready to be discharged from the hospital, get everything in order for them so that it's in place and they can leave and they are still being cared for in some capacity following the discharge from the hospital. So the way that usually works is almost 100% of the time when a patient goes home, they have a home health company following them for a period of time. And the social worker is the person that sets it up. The data they give the patient to make their choice is very minimal. It usually consists of a name, company location, what area they service, whether they're certified by any organizations, and do they service your area, and what insurances they accept. So here I have a picture of a patient throwing a dart at a dartboard because, how do you make a decision on that? Really what you care about is, are you going to get better? Who is going to help me get better the most? Is there a company that will get me back on my feet quicker than the other ones? So what's the solution? In the upper right-hand quadrant of the storyboard, I show an expert teaching experts in training how to take care of the cardiac surgery patient after they're being discharged. And I think it's important really to have this focus on cardiac surgery patients alone. Traditionally, most home health companies take all comers. Sometimes they have some sort of focus, but it's not as focused as specifically cardiac surgery. So what's the activity? After the patient is discharged from the hospital, they go home and they are continued with care by a home health company that comes to their house and monitors them. So some opportunities to make a difference in these patients' lives is really to monitor them more closely, to understand what complications might arise and commonly arise after surgery. In other words, what puts them back into the hospital. And noticing these problems very early on, notifying the doctor, having excellent communication with the patient, with the doctor, with the home health company, and making sure everyone's on the same page and making the problem go away before it becomes so bad that they need to get readmitted into the hospital. And the outcome, obviously, we want the patients getting back to their activities of daily life as quickly and as safely as possible. And that may be different things for different people, depending on their baseline preoperative status. Other outcomes include, obviously, increased patient satisfaction, improved quality of life for the patient, fewer readmissions to the hospital, a better reputation of the hospital and the surgeon. These hospitals and surgeons are being graded upon their results, and readmissions and complication rates get monitored. And finally, another outcome is increased cost savings. Primarily, it goes to the hospital, since the hospital, the way the insurances are set up right now, the hospital bears the burden for the readmission due to bundled payments. So hospitals really have to eat the cost of the readmission solely themselves, not the insurance company typically, and not the patient usually, although sometimes it could go that way. Stanford School of Design has, they describe 5 stages for design thinking, and they are empathy, defining the problem, creating solutions, prototyping, and testing. And right now, my key questions really focus on the second and third stages, which are defining the problem and also creating some solutions. So I think it's important to kind of do both of those things at the same time, especially if you believe there's a problem, you sort of want to dabble with the solutions. And what I mean by dabble is understand what other people think the problem is, what solutions have they tried to do themselves, what have they found useful. And so combining those two things is kind of where I'm at. And these are my key questions. Is there really a need in the marketplace for a home healthcare company focusing exclusively on heart surgery patients? And not only is there a need, but is there a perceived need? And the two are different. There could be a need, not a perceived need. There could be a perceived need, not a need. And there could be, you could have neither. You could have all 4 quadrants. And I think it's important to know, even if there's a need, it's important, it's helpful to have a perceived need also. It just makes it easier to get customers if there's a perceived need. If there's not a perceived need, you will have to spend quite a bit of time possibly educating people to show that there's a need, to really let them know the value that you're creating for them. So I think it's important. Doesn't mean you can't take on the challenge of filling a need when there's not a perceived need. It just will make it more difficult. And I think it's good to know up front what you're up against. So these are my questions. The experiments that I'm going to design are really based around these key questions. What are the primary and secondary targets? Another way of saying it is the value propositions for the company. Preliminarily, I've done a little bit of research. I think there may be some improvement in readmission rates, cost savings, patient satisfaction, perhaps. And will hospitals present this company to patients as an option for their home health care? So just because I create a company doesn't mean patients will even know about it. They really only know about the companies that are presented to them by the social worker. So how do I get on that list? In other words, I want to be there if I have a company. And will patients choose this company for their home health needs? Just because I get on the list doesn't mean they're going to pick me. And what's their process for deciding on who to choose and why do they choose it? These are important questions for me to understand really from the beginning, to know how to really develop a company, to focus on what patients, social workers, all the stakeholders need from me. And how would the company be able to meet those targets is the last key question I have on here. Believe me, I have a lot more questions. And getting answers, and as I'm getting answers, I'm actually sort of developing more questions. And it's kind of this iterative process in some ways of learning and exploring and thinking and being creative and thinking of new questions to ask and thinking of new solutions and new ways of doing things. So how would we meet those targets? What resources do we need? What expertise do we need? Can we acquire those things when needed? So who are the key stakeholders in this process? And obviously the patients are probably the main stakeholder in this. They just had a major surgery. They're going home. They're nervous. They're scared. They want to make sure that they're well taken care of when they get home. So their outcome and their result is probably of prime concern, and patients are definitely a stakeholder. And they get to choose. They decide which company will be coming to their home to take care of them in their house for their home health care needs following discharge from the hospital. The hospitals are definitely a key stakeholder. They may or may not know it, but the home health care that's received from the patient at home can make a difference in terms of outcome, readmission rates, complications, and it can turn into a costly thing for a hospital if a patient is not taken care of as well as possible, and they do develop a complication and it doesn't get noticed. Um, it can turn into a costly thing for the hospitals. And it can also cost the surgeons some of their reputation. They may not make the highest grade on the quality survey studies, which may result in less referrals and a lower reputation and less revenue for them and the hospitals. So, and obviously, employees of the home health care company are definitely a key stakeholder as well. Employees want to be appreciated, they want to be cared for by their company, and they also want to be on a mission and know they're doing a good thing and making the world a better place. So I think, the way I see it, these are the primary stakeholders at this point. So I have these important questions, and how do we get the answers? And one of the ways we can do it is by creating experiments. So I went ahead and created 3 mini experiments, and following that, I did create 2 pilots studies. One I won't do, and one I will do, hopefully, if we get to that point. So, but first, I really am working on defining the problem and creating solutions. So I think I know some of the problems. I don't think I know all of them. And the more I'm aware of, the better my solutions could be. So I think this is really an important part of the process for me. Not only understanding the main problem, but also understanding some of the smaller problems, the nuances that the social workers might face. Sometimes the little things can make a big difference for people, making life easier for all the stakeholders would be ideal, I think. And also, in defining the problem along the way, I'm asking a lot of people, I'm interviewing a lot of people, including surgeons, social workers, hospital administrators, clinicians. And all of these people can have the potential to be a big supporter of the idea, especially if they think it's going to make their lives easier or be something innovative and better for their patients. And so I kind of feel like this part of the process is actually promoting the business in a way, because these people that I talk with and interview and shadow and observe, they could end up being a client and and a big supporter of the idea. So it's not wasted time. Even if I was to fully understand the problem, it's still not wasted time. So this really is an important part of the process for me. And I intend to really spend a lot of time on understanding all the problems. And I just think it'll come to a better solution. So let's get on with it. Mini experiment number 1 is interviewing the surgeons. As I mentioned on the previous slide, a surgeon is one of the key stakeholders in this process. The surgeons have reputations. They have online reputations. They have they're graded by things like health grades. Pennsylvania has a Pennsylvania Health Care Cost Containment Council. It's also called PHC4, and they grade the hospitals and surgeons based on their outcomes, and part of their outcomes is the readmission rate. So they may get 1, 2, or 3 stars by this organization. And there's also the Society of Thoracic Surgeons also has a grading system as well for postoperative patients. So, and when doing an interview, it's important to keep the questions very open, not too specific. An open-ended question can give you an answer that you're not expecting. A very direct, specific question will not likely return a response that you're not anticipating because it's so focused. There's not as many options, not as many different ways to answer the question. So all these questions are very open. And really, what I want is to hear the surgeon describe problems that they're facing. And without me alluding to it or asking specifically, do you have a problem with your postoperative patients after they go home? It's a very leading question, and the answer may not be as indicative of how they really feel if they were to bring it up on their own. It brings more credence to me. So anyway, that's why the questions are very open-ended. So the questions I intend to ask are, what challenges are you facing with your patients following discharge from the hospital? What are you doing about these challenges? I think that's an important question because it shows you if they're trying something that they definitely think there's a problem and they're even trying to fix it. And, the last question is, what is the best solution towards these challenges? And they may have an answer that they think is the best solution, and why not ask them what it is? And maybe they're right. Maybe you agree with them. Maybe other people agree with them too. And maybe the solution that they think is the best is something they're not able to get set up on their own, or they need a little help, or they don't have the time. And a company like mine could come in and solve that problem for them. And also, as these questions are going on, I think it's important to sort of evaluate how the surgeon feels. Do they look like they're in pain? And find out how it's affecting them. So, and that's what I have at the bottom is, you want to observe a little bit as you're interviewing. Facial expressions can be a little bit revealing too, as much as what they're saying to you. And so I have a picture of Einstein here, and the amazing thing about Einstein was his incredible ability to observe. And I think, he's come up with amazing theories, amazing formulas, amazing solutions. But really, his observation of the world and the universe led him to realize there were problems in the universe and there are discrepancies that aren't easily explained. And he developed solutions to these problems. And that's how he came up with his amazing formulas. And really, I think at the crux of it all is his amazing ability to observe and identify problems and create solutions. And it's really all the things that I want to do as an entrepreneur. And so I think this is a great caricature of him and of what I'm trying to do too. So with as an entrepreneur. So I set up experiment number 2. It's a mini observation, and it's observation of a social worker and patient interaction. So as I described earlier, the social workers visit the patients prior to their discharge, and they get the discharge planning set up for them. So when a patient goes home, things are seamless. A home health care person shows up. If blood draws are needed, the blood draws showed up. If there's durable medical equipment, supplies that need to get delivered to the patient's house, that's there, ready for them when they're entering their home. And so the process of observation is really important. Again, like the interviews, I think it's good to keep an open mind and have an open concept. Just like the open questions, you have an open concept. You don't try not to bring your preconceived notions as to the way things are, and just see them for how they really are. Just observe and notice and write down, and then at some point along the way you want to create your insights from your observation. But the things that I will be observing are the space. What's it like? Is it crowded in the patient's room? Is it noisy? Does the patient have a roommate? Is it hard to concentrate? Those factors may play a role in this process. Who else is in the room? Is there someone else in the room besides the social worker? Is there a nurse taking care of another patient in the room? Is the nurse taking care of this patient at the same time as you? Are the things that are interfering with the activity? And what is the activity? What is it comprised of? Are there objects in the activity that are given to the patient to see, to feel, to touch, to help them with their decision? What is the communication like? What's the act of what's going on? Is there communication between the social worker and the patients? Are the patients given chances to ask questions? Are their questions answered adequately for the patient from their perspective? And who is presented to the patient, and how are they presented, and why? And all these questions really are what you're asking about each observation, the act, the event, the time. The time can be important. It just sort of depends on the scenario. So it's important to keep it in mind, to keep track of it. Conversation may change depending on the time of day. If it's getting close to closing time for the home health companies, is the social worker rushing with the patient so they can get in their orders before the home health care company closes, or doesn't answer their phone as timely, or maybe the social worker themselves have something they need to get to. What are the goals of the interaction? How does it feel for the patient? How does it feel for the social worker? Are there frustrations? Are there anxieties, fears? And what are they? What are the fears? What are the anxieties? And then finally, after all that, you want to develop your insights based on your observations. Mini experiment number 3 is also another interview, and it's using interviewing social workers, clinicians, and hospital administrators really as a proxy for the hospital itself. There's no one single real representative of the hospital that can really answer these questions. It's really a combination of several people, and in combination together, they may wish to use the service or may choose not to. So, and they have certain needs, and they're not all the same. It's not the same between the social worker and the clinician and the hospital administrator. So I think it's important to interview all these persons. They all really are stakeholders. The hospital administrators are typically the people that make the decisions and choose which companies to use, whether it's home health in the traditional sense, or if there's a solution that's maybe non-traditional, they definitely would be involved in the decision making for that. If there was a way to take care of the patients post-operatively to prevent readmissions that wasn't in the traditional sense of home health care company, but perhaps some hybrid of some kind. So, I think it's important when you're an entrepreneur not to get so focused on having to do things the way it's always been done. There probably is a reason why things are done the way they are, and I think it's good to know that. However, I think it's also wise to keep your mind open, be creative, look for solutions that maybe aren't mainstream. And if it's not mainstream and it works, then you're kind of in a category of your own, which is kind of nice. So that's how I'm approaching this. I want to interview social workers, clinicians, administrators, and ask them what challenges they're facing with their patients following discharge from the hospital. What are they doing about the challenges? It's really the same open questions that I asked the surgeons. And the insights from this can be really valuable because if a service or product is created that can really alleviate the problems of all the stakeholders, it'll probably receive more support from all of them, and it could lead to a viable business. So I think that's what we're going for. Is it feasible? Is it viable? Is it desirable? Most important thing. And the more problems you fix for people, the more desirable it's going to be for them. So that's why I'm all about interviewing a lot of people. And these, like I mentioned earlier, are potential clients. So, and they're potential supporters of the company that I'm trying to create. And if they feel like they have a part in developing it, they might even be more likely to support it. So that's really what I'm going for here. And it's more, it's not just identifying the problems, it's also working with people, getting their input, um, allowing them to feel like they're part of the process and the decision making. And really they are, but it's important for them to feel that way too. So that is mini experiment number 3. So next I'll describe to you pilot experiment number 1. It's a physician assistant home visitation program. It was actually performed already at a different hospital up in Long Island, New York. And it was a study where they split their patients for 13 months into 2 different groups. And one was the control group. The other group had visitations twice in the first week following surgery, following their discharge from the hospital. And the 2 groups were then compared. And what they found, what they looked at was they looked at the readmission rates, they looked at the diagnosis at readmission, and they also looked at the home visits themselves, what interventions were made and how frequently and what were they. They categorized them as like medicine changes, some other kind of intervention. They found that most of the interventions were actually medical interventions and related to things like diuretics, which has to do with fluid volume status, and also insulin, which has to do with sugar, which can result in complications, either sugar too low or too high. Both have complications associated with it. So that's what they did. You know, the way I look at this is I'm being a scientist, but I'm not being too much of a scientist. I didn't have to create the whole protocol. I think what they looked at was really good. The fact that they did this study alone, to me, suggests that they thought perhaps there was a problem and perhaps there was a solution to the problem. And that's the way it played out in their data. It's now published. It was in a cardiovascular and thoracic journal, and it's also on the National Institute of Health website. The link is at the bottom if you want to look at it more closely, but I could replicate this same exact study at another hospital if I have to. I don't want to. It's a 13-month study. Really, you need their p-values, I think, were 0.1 and 0.01. And to get the 0.1 value, they saw 600 patients. And really, to see 600 patients, it'll take, at one hospital, it'll take a year. If you have 2 hospitals, you might be able to do it in 6 months. If you have 4 hospitals, you know, maybe you could do it in 2 or 3 months. However, it gets complicated. A study like that is a big undertaking. And to be real honest, my pilot experiment number 2, which is actually getting a company up and running on a smaller scale, is less work than the study itself. So I don't really see the point in doing this. I am so grateful that it has been done. It's really the premise, the insight that I've noticed, I've observed over the years, that patients, I think, deserve better care at home. You know, they're not intentionally neglected. I think the home health companies aren't experts in cardiac surgery, and they're the ones that are tasked with taking care of these patients. And it's a big ask of them, I think. And I think an expert taking care of them, you know, whether it's a nurse or a PA, I think the key is really having expert care at home, and that's what I'm looking at right now. I think I'd be remiss not to say the benefits of doing this particular pilot experiment. Even though it's been done before, I think the value of doing it at a different facility is, one, it removes the question of reproducibility. And I think that's important. You know, as clients look at the study, they think, well, that's great for them, but we're already doing everything we can, and there's no way to improve, and, you know, you're wasting your time. So you could do a study to sort of tease that question out. is it reproducible at another facility? And also, at the same time, if it is reproducible, it'll show that there is a tremendous benefit. You can actually calculate it down to the dime or the penny, or have a rough estimate of range of cost savings per year. So there is benefit to doing the study. I think it should be noted, the value in it. So if and or when the business looks like it's ready to get started, I intend to start it through pilot experiment number 2, which is really a small scale functioning of the company. I have no interest in opening up the service nationwide or even to all the hospitals in Philadelphia. What I'm interested in doing is getting started, not worrying about the profits. As long as it's break even, I don't think it's too difficult to get that close to break even. And then the real goal of doing the pilot experiment is to find a hospital that really wants to partner. They're committed to this. They're willing to spend perhaps 12 months getting data and comparing it to the baseline. And the hope would be that we are able to reproduce the results that they saw up in Long Island. And the way we would go about this is we would actually get our business licenses, get our insurances, get the certifications we need from the certifying organizations, hire personnel, train them, and get started and see how we do. And just because we're doing it one way on day one doesn't mean we need to continue always doing that. It's not going to be that kind of study. It's going to be a go out there as experts, learn as you're going along, keep observations, let me and other people know what the issues are out there, and really get the employees all the tools that they need to monitor the patients better, to have a better communication with the surgeons and with the home health company and the patient, and get everybody on the same page. It may be some sort of technology involved in that. And really follow the patients for at least 30 days, maybe longer, depending on what the hospital is interested in doing and what we can work out with finances. Traditionally, home health companies don't follow patients for more than 30 days, but I do see some potential value in a little closer follow-up than that. The data would be things like the home interventions, the calls to the physicians, what the intervention was, and readmission rates. Like long-term data, this is kind of an interesting one. The LOS there is length of stay. I have spoken to one hospital in Jersey, and they have set up their own system for taking care of post-operative, post-discharge patients. And it was really neat to see them really on the ball like this. But they obviously identified a problem, and they hired a couple PAs, and they're hiring more now, actually. So it's been successful. But they've hired some PAs to keep closer tabs on the patients after their discharge. They don't actually visit in their homes, but they follow up with phone calls very closely and some very pertinent questions. And they found that by doing this, they're able to send patients home earlier and still keep their readmission rates down. So they have the front end cost savings of sending a patient home a day early, and they have the back end of fewer readmissions, and it really saves the hospital a lot of money. I was not able to get numbers on that from them, but they are investing in it, so they believe it's important. And there's the other outcomes too, the patient satisfaction, which ultimately may turn into some sort of monetary. The government's looking at that now. They call it HCAHPS scores, paying certain hospitals with better patient satisfaction scores more money, basically, a couple percent, but it adds up. So what are the hypotheses of this experiment? The primary one is reduced 30-day readmission. And then the secondary one, which honestly, depending on the comfort of the hospital, may or may not play out, but it could if they have the trust to send their patients home. The patients that maybe they would keep one other day, they're doing fine, but they want to make sure they don't get worse. Those patients, they can send them home, and if they do get a little worse, we could still take care of them at home. They're still not so sick that they would need to be in the hospital right away. So that is pilot study number 2. It would be extremely exciting to get to this someday. It probably won't be very soon, unfortunately. Got a little work to do before then. In following the Stanford Design School, the 5 stages of design thinking, we've obviously had empathy, we've identified problems, we've created solutions, and now this pilot experiment number 2 really is our prototype. And what we want to do is follow this prototype and test it. And the way we do that is really get out there, take care of the patients the best we can, build things, measure things, learn from it, and refine the process. Iterative learning is really important. I use the words build, measure, learn. Those are the words of Eric Rees, student of Steve Blank. But our Heidi Neck talks about divergent and convergent thinking. Empathy is really inspiration. Ideation is creating something, and then implementation is testing it. So very similar concepts. It's just kind of been ingrained into me to build, measure, learn. Those are the words I go to. But same concepts as NEC. And the important thing is really not just measure the final outcome, the readmission rates, but measure everything. Patient satisfaction, how well do we really monitor our patients? Can we get better at it? Can we get better at the communication? Can payroll be more consistent and error-free? And can we bill appropriately, not get rejected on our billing? All those processes is really what we're going for in this prototype, refining them, getting them running as efficiently as possible, and getting ready, if we're successful, to scale to a larger size. And that's really when I think things get exciting. I'd be pretty excited to be in the pilot experiment, and it probably won't come soon enough for me. I just want to give a quick update of where I am today on this whole process. Fortunately, I have had the opportunity to do several interviews with a couple social workers, 3 or 4 clinicians, a surgeon, and I'm in the process of setting up an interview with an administrator. So what are the insights that I've been able to glean today? Patients need to make choices about their care with data that is insufficient to really make a full or complete decision. Patients have a lot of concerns surrounding their discharge, like how will they be able to function at home, who will provide them adequate care that they need following the discharge, who or how will they be able to pay for the home health care costs. Cost is an important thing to people. They want to know they're not getting stuck with a large bill without the value to go along with it. The social worker is in a privileged position and has gained the trust of the patient. The social worker has asked many questions about which company is better for the patient. And the social worker is in a position to influence the patient's decision based upon biases, preferences, or experiences that they've had. So the insights as represented by the Warby Parker glasses at the bottom right. So the social workers want home health care with amazing accessibility. They prefer a company that has a representative inside their own hospital within walking distance of the patient's room. They would prefer home health care that has electronic medical record access to get the patient information, as opposed to getting the information from the social worker who has to write down information from the EMR or fax it over to a home health company. They also really appreciate it when the home health care company can set up the durable medical equipment and any lab draws that the patient may need. other ancillary studies. One of the insights I had in an interview with a social worker was they thought it would be a good idea to visit an outpatient office to discuss with office staff about their perceptions of current home health care performance. And I'm in the process of setting that up with a clinician. Probably it's not going to happen next week, but perhaps the week after that. And then I was given some introductions, which is always an important thing. The insights I've been able to get from the surgeon are very similar to my experiences. I've noticed that most surgeons are concerned with their patient data for the 30 days following the surgery. That's really what they're measured on. That's the metrics of quality data that gets published out in the world. And so that's what they are most concerned about when it comes to data. And the surgeon explained that the most common causes of readmission were pleural effusions, congestive heart failure, atrial fibrillation or an abnormal heart rate, beat, deep venous thrombosis or blood clots, and wound infections are the most common cause for readmissions. The surgeon believes there should be better communication between the home health care companies and the surgeons. My guess is the home health care companies have no idea that a surgeon would say that or think that. They probably don't want to bother them. That's probably the mindset at the current moment. The surgeon believes there could be better home monitoring, like EKGs, telemedicine of some kind. He mentioned a surgeon who's developing some better monitoring tools to track his patients at home, I guess. I haven't reached out to him yet. I'm excited to hear what he is doing with his patients. In conclusion, the questions about feasibility, viability, desirability are getting answered. It's a fairly slow process, but part of the process is really talking to the people that are the stakeholders and future clients. So I have no problem taking my time in this part of the process. They, in some ways, feel like they're a part of developing the company and have some say in it. And they may think that the company that gets developed is somehow reflective of them and has components of their advice in it, and it probably will. I do need many more interviews to really be certain about my conclusions. So far, a lot of my thoughts have been confirmed, but I think I've read somewhere, I don't know if it was in NEC or somewhere else, but if you can get 6 people to say the same thing, then it can be a conclusion. The real world really demands bypass a pilot study. One that I described earlier, it's a 13-month study at one hospital. I can do it if I have to, if it's the only way to really show benefits to a hospital and nobody else is really sees the problem the way I do, then we could go that route. I don't know if I would or not. I could, and I'm willing to do it. It's a lot of work. So somehow, if it can be bypassed, I think it should be. I'm grateful for the study. It is good evidence that I can use and good support for my hypothesis. So the questions about desirability remains. Do patients understand the choice they are making? Will hospitals be willing to invest financially to the idea of reducing readmissions? And who will be the early adopter for the pilot study number 2? The end.